This first case is a patient that presented to me in her 70s after several of her friends had had refractive cataract surgery with me, and they were church friends, and she came in asking for a lens implant, a multifocal lens implant, specifically by name, because this is what her friends had. And when you'll look at these pictures of her corneas, you'll see that she had extensive Salzmann's nodular degeneration, to the extent that biometry was going to be impossible. And any surgeon out there looking at these pictures would be able to tell you that they would never consider this a candidate for let alone a multifocal lens or an accommodating presbyopic correcting lens. But really the cataract surgery, even from the get-go, is difficult because the preoperative biometry was going to be so inaccurate. And as you can see from the pictures of these placido disc images, the preoperative biometry was going to be significantly swayed and skewed by the heavy amount of irregular astigmatism. So doing cataract surgery on this patient, let alone a advanced intraocular lens, was going to be a challenge. Under normal circumstances, any surgeon would probably have dismissed this patient as a cataract candidate or sent them to their favorite colleague across town. But in looking at this patient, I saw an opportunity to treat the ocular surface and bring this patient to a stage where they could successfully undergo refractive cataract surgery. In order to bring this patient to a state where they could successfully have accurate biometry performed and refractive cataract surgery as she desired, the first issue was to deal with the Salzmann's nodular degeneration and smooth out that cornea so that we could get accurate topographies and K readings. So whereas normally I would have maybe taken this patient to the operating room for a superficial keratectomy and sutured on an amniotic membrane graft to promote healing, in this particular instance I was able to do a superficial keratectomy at the slit lamp in the clinic at the point of diagnosis, smooth out that cornea and place an amniotic membrane graft that was self-retaining, and be able to promote this patient's healing very, very quickly. So after the superficial keratectomy of this patient, we placed a Procaragraft on her for approximately 1 week. She attained full 100% reepithelialization without any subepithelial haze or scar tissue, and we were able to achieve accurate enough biometry. As you can see from the post-treatment placido disc images, the biometry was much more accurate, and rather than giving her the multifocal lens implant that she desired, we were actually able to place a presbyopic correcting implant, an accommodating lens that met her needs, and she came away very, very satisfied, as much as her surgeon was.